talk a little bit more about the ARIA specifically, if this drug were to get approved, which we're all kind of hoping for at this point.
Yes.
Is that, how should clinicians approach ARIA for this drug specifically? Is there any differences in how they would approach it versus other types of incidences?
Yeah, I think this is a critical question, Marco. Let's kind of break it into pieces. The first thing that people are not paying attention to is that in order for a patient to get a lecanemab, we will not only have to prove that they have mild cognitive impairment or mild dementia, we have to prove that they have amyloid in their brain. But the things that we're not talking about are, we're going to do a baseline MRI, a screening MRI. And the patients who cannot get MRI, meaning pacemakers, I'm sorry, but that's going to be a hard no. Until the label changes, there's no way, if you cannot get an MRI, you need to get that. So that's going to be something that needs to be looked at. But the things that not are discussed is that it turns out that baseline MRI will predict future ARIA rates. So if the literature clearly suggests if you have 5 or fewer microhemorrhages, your risk of ARIA is very low. And if you have more than 10, your risk of ARIA is very high. And so I suspect we're going to want to use checklists like order sets, and we do this with a lot of other diseases, and say, have you checked the boxes? And many patients might get excluded because they have a lot of microhemorrhages and pacemakers and other conditions, or don't have amyloid, or are too old, or are too sick, or have too many comorbidities. So a lot of things are going to exclude patients from getting lecanemab. The other thing is that since we know that the ARIA rates tend to occur on the front end, meaning in the first 90 to 180 days, I think what you'll see is more MRIs and more vigilance and more surveillance at the front end of the study. Fortunately, most of them resolved without treatment, but my point is that we're going to want to address a lot of these concerns at the beginning of the study and not let that get out of control.
If approved again, this would kind of be the second straight anti-amyloid therapy to be approved within the last sort of 2 years. So what does that say about where the space is going right now? And how might this also set up the future for therapeutics?
Yeah. So you and I have followed this field for a long, long time, or been part of this field for a long, long time. This is the second time we see a phenomenon known as directional concordance. The PRIME study of aducanumab was the first time we saw it. And what is directional concordance? It is in a dose-dependent manner. The higher the dose, the more amyloid was removed, and the more slowing in the rate of decline. Until that PRIME study was done, we had never seen that before. We either saw a signal or biomarker. But this was the first time the biomarker and the clinical signal went in the same direction. So then we saw this in the 201 lecanemab, a directional concordance signal, and Clarity puts the exclamation point that the more amyloid you remove, the more slowing in the rate of decline. And so I think that kind of puts to bed the controversies around, is amyloid hypothesis still relevant? The people who are saying stuff like that are not they're not in the weeds. They're not living in the field that we live in. So I think that's been very optimistic. And I think, we could see another monoclonal report out a similar kind of thing in the very near future. So I feel like we're now understanding that clearance-based approaches of amyloid are making sense. They will be applied in a selected population who are mildly affected, and that we're going to use biomarker confirmation to get the patients to treatment.